Good day, morning, evening. I'm not sure when you're catching this. So this is Jess, and this is one of a series of different YouTube recordings about diabetes mellitus. Like I said in orientation, there's two major types of diabetes. There's mellitus and insipidus. Now these chapters are going to be about mellitus. So let me share my screen so that we can there we go. Get into it. All right. So diabetes mellitus is a condition of the endocrine system, and it's a multi-system disease. It's characterized by hyperglycemia related to abnormal insulin production, impaired insulin use, or both. About 29 million, 29.1 million people in the United States have it. Of that, 8.1 million people in the United States are unaware that they have diabetes mellitus, and 86 million people have prediabetes. It's the seventh leading cause of death. It's also the leading cause of adult blindness, end-stage renal disease, and non-traumatic lower limb amputations. We'll get into the pathophysiology behind why that is a little bit. And it's a major contributing factor to heart disease, stroke, and many people with diabetes have hypertension and high cholesterol. So the other day when I was talking in orientation about being kind of like a hot dish of different sorts of things, diabetes, DM is definitely one of those factors. It's a primary component of your hot dish. The American Diabetes Association recognizes 4 different classes of diabetes. So there's type 1. Sometimes those of us who've been around for a couple days used to refer to this as juvenile onset or insulin dependent. There's also type 2, which is otherwise known as adult onset or non-insulin dependent diabetes. There's gestational diabetes, and that's specific to a specific time in a woman's life. And there's another one too. So just to let you know, for the most part, this particular course is going to focus on type 1 and type 2 diabetes. We're not going to be talking about gestational or other forms of diabetes mellitus. So here are the comparisons of type 1 and type 2 diabetes. So you can see that there is a far less prevalence of type 1 than there is of type 2. There are far fewer environmental external factors that cause type 1 in comparison to type 2. There is some different antibody reactions that cause these things. So type 1 is caused by islet cell antibodies. There is an immune reaction to those islet cells, and the immune reaction is to kill off the islet cells. Therefore, there is no insulin. In a person with type 2 diabetes, that is not the case. That's not how they developed their insulin or their hyperglycemia tendencies. Their hyperglycemia tendencies are determined by insulin resistance, decreased production, and then altered adaptogenic as well. So just to continue it down, there are the main difference between type 1 and type 2 is type 1 diabetics don't make insulin. So endogenous insulin, self-made insulin, endogenous, self-made, they don't do it. Their islet cells got killed off by their autoimmune problem, and they don't have the capability to make insulin anymore. In type 2 diabetics, it's initially increased because the body's like, oh my gosh, I see all this extra stuff. Maybe I'll shoot some extra insulin at it and see if it helps. But then the secretion eventually, then it just they give up. Like I'll do some, but like, wow, I'm really overwhelmed. That type of if your islet cells could talk, that's probably what they would say. As well as, and we'll get in, there'll be more about this. This is just kind of the precursor. So if you're thinking I'm kind of skipping through this, I kind of am, because we're going to get there. It's a big overview of the next 70 some slides. So normally, this is how normal insulin works. So normally, insulin will promote glucose transport from the bloodstream across the cell membrane into the cytoplasm of the cell. So if you want to think about it this way, sometimes when people need a more relatable sort of explanation for insulin, insulin is the gas pump. So there is gas at the gas station. There is a car. The car is running low on fuel, and the gas pump that you take off of and you insert the nozzle into the gas tank, that pump right there, that's the insulin. So the insulin facilitates the transfer of the glucose from outside of the cell to inside of the cell. The insulin, the gas pump facilitates the transfer from the gas underneath the gas station in the reservoir tanks to in the car where it can be used. So just in a normal sort of insulin sort of situation, the cells are going to be breaking down glucose. They make energy. Liver cells and muscle cells store extra glucose as glycogen. And then we can use anabolic, a storage hormone to convert that glucose to glycogen. If you have increased insulin, it inhibits gluconeogenesis, meaning that you have increased fat deposits and it increases protein synthesis. Low systemic insulin will release glucose from the liver and start that gluconeogenesis from the liver. It will release proteins from the muscles, ketosis, and fat from adipose tissue, ketosis. So there are some different counter-regulatory hormones to insulin, because usually for whatever hormone there is doing one action, there's another hormone that doesn't equal, very yin-yang. So hormone has one action, there will be another hormone that has an opposite reaction. So glucagon, epinephrine, growth hormone, and cortisol all oppose the side effects of insulin, or not side effects, the regular effects of insulin. They stimulate glucose production and glucose released by the liver. They decrease movement of glucose into the cell, and they help maintain normal blood glucose levels, just so you know. So as a person goes through, depending upon what type they have, there's some different mechanisms that are altered. So in type 1 diabetes, you'll see that there's atom destruction of those islet cells. The antibodies can be present for months to years before clinical symptoms happen, and then all of a sudden they're triggered and there's insufficient production of insulin because there is no islet cells because the antibodies took it out. They took out those islet cells. When type 2 diabetes, there's 4 different factors. So this is where type 2 diabetics can get really confused and really lost about their pathophysiology. And so there is, we'll just go at it from each different picture that we have here. So there's the pancreas, and there is defective secretion of insulin. Remember, if you have insulin resistance, meaning that the cells are sending out stress hormones saying, I need more sugar. And then they're sending out, and they're using ketosis, they're using anaerobic metabolism to be able to get things done. That's actually going to stimulate an increase in insulin secretion. But because there's just like all of us, islet cells only have so much energy and they get tired. So eventually they exhaust, they just wear out. And then they'll be also associated with this, there'll be increased glucagon secretion. In the liver, there is excess glucose production. So there's a lot of, because the liver is getting the distress signals too, like, I need more sugar, please send me more sugar. And the liver's like, hey, and so it will increase glucose production as well. So then we have glucose floating around in the body because of the liver as well. And then because of the distress signals coming from the cells who are going through anaerobic metabolism rather than aerobic metabolism, then you'll end up having inappropriate regulation of that glucose production too. Adipose tissue results in altered glucose and fat metabolism as well, because of the relationship between adiponectin and leptin. And muscles will have eventually, in type 2 people with type 2 diabetes will have defective insulin receptors. They'll have insulin resistance and decreased reuptake of glucose by cells, resulting in hyperglycemia. Basically, not only are the cells not getting enough insulin there's not enough gas stations to be able to get the gas from the gas tank or the storage tanks into the cars, but also there's like a lack of insulin, and sometimes there's faulty gas pumps. So the insulin receptors aren't effective at recognizing the fact that you could actually need some gas. So there's two different ways that there's insulin impacted by type 2 diabetes mellitus. So I did mention prediabetes when I was going through some of the epidemiology, and prediabetes, it just puts you at risk for developing type 2. There is an impaired glucose tolerance. So if you have a glucose tolerance test, and an oral glucose tolerance test, OGTT, reveals a glucose level of 140 to 199. There's also an impaired fasting glucose that we can do as a test, as a lab test. And that means that you haven't had anything to eat for at least 8 hours, and a person still has a fasting glucose of 100 to 125. You may have people who get both an oral glucose tolerance test and a fasting glucose. There is a normal, prediabetes is considered an intermediate stage between normal homeostasis and using aerobic metabolism and having diabetes mellitus. Prediabetes is usually asymptomatic, but there is long-term damage already occurring. So patient teaching is super important. We'll be teaching them about how to undergo screening, both for like the fasting glucose test, and then we'll start doing this hemoglobin A1C. You'll see hemoglobin A1C, HDB A1C a lot in these chapters, just to let you know. And then we're going to be teaching people how to learn and manage their risk factors, monitoring for symptoms of diabetes, and then maintaining healthy weight, exercise, and making healthy food choices. Gestational diabetes, I'm just going to do a quick hit on this. But like I said, there is very little about gestational diabetes on your exam, because you talk about gestational diabetes a lot in semester 3 when we're talking about the maternal child considerations. But it does develop during pregnancy. About 2 to 10% of people in the United States have gestational diabetes. It increases the mother's risk for cesarean delivery, and then it also has impacts on the neonate and on the baby that's being born as well. There are going to be screenings that are done, high-risk patients during their first visit, people who are obese, advanced maternal age, and family history. Advanced maternal age is not necessarily like a 50-year-old having a baby. It's anybody over the age of 35. We used to call them geriatric mothers, and that was just an awful, awful term. So now we call them of advanced maternal age, and it's usually people who are over the age of 55. So average risk is 24 to 28 weeks of gestation is usually when we try and hit this. That's usually when we'll do that oral glucose tolerance test. And then just to let you know, the kid has if the mom has gestational diabetes, the kid has about 63% of developing type 2 diabetes within 16 years. So other specific types of diabetes result from injury to or interference with or destruction of B cell function in the pancreas. It could be from medical conditions. It could be from medications, drugs. It resolves when the underlying condition is treated or the drug is discontinued. So if for whatever reason we have a medication that's really hitting somebody's pancreas super hard, or people who have extreme pancreatitis, a swelling of the pancreas, may not be producing enough insulin either. And in either case, lack of insulin indicates a predisposition towards diabetes mellitus, and therefore a problem. So let me stop sharing here, and I'm going to continue on with chapter 2 of diabetes mellitus in the next recording. I will see you then.